right? So it's like, okay.
Yes.
Yeah. So thank you for inviting me to do this interview. I'm excited to be here and to be interviewed. And so my background is a little unusual because I'm a sociologist by training, and I call myself an applied sociologist. And I'll explain what that means in a moment. But right now, in the last 2 months, starting February 1 of 2018, I assumed a new position as the Dean, La Decana, no? of the College of Nursing and Health Professions at Drexel University, which is in Philadelphia. And before that, I developed and directed a center on innovative care in aging at the School of Nursing at Johns Hopkins. And before that, I was involved with the Department of Occupational Therapy and Nursing and Physical Therapy at Thomas Jefferson University, and I directed various centers there. So I've always been involved with
How do you find this relation or this, discover in your career as a sociologist?
Yes, so, as a sociologist, I was trained to look at human behavior and everyday life from a big picture, from understanding how social policies and health care organization influences health on an individual basis. And so I bring what is called a social ecological lens to understanding healthcare, and that's a very applied approach in sociology. And I have always been involved in developing and testing different health programs, primarily for older adults. And so I've always worked with teams of health providers, occupational therapists in particular, but also nurses and geriatricians and neuropsychiatrists and physical therapists and social workers. So I've always formed teams to see how to bring my sociological lens and understanding of individuals within their living environment and how policy and neighborhood arrangements and so forth influence healthcare and how we can make a difference. So I've been very applied my entire career.
Okay, the multidisciplinary teams are fundamental for you to find this relation.
That is correct. So I have been, that's absolutely right. I've been forced, if you will, to work with teams. I'm not a clinician, although I also can think clinically. I'm not formally trained clinically. And so partnering with clinicians is a very important part of how I approach healthcare. And so for me, working with a team and having it be multidisciplinary is just what it is. This is how it has to be. And I really think that's the wave of the future, but that's what I feel most comfortable with, and that's how I have proceeded in my career.
Nice.
Not everybody thinks that way, but I think that's the way to think.
How can you explain the importance between health and lifestyles in vulnerable people to make their life better?
Yeah.
Can you develop this idea?
Sure. Yeah, so the relationship to health and lifestyle is now being recognized as a very important association. I think before, and just really until very recently, the thought was that our health is really very much genetically predetermined, and that we can't really do too much about it. But there's lots of research that has shown that that is not the case at all, and how the life choices we make and how we live our life, as well as the context in which we're grown up in, very much influences brain development, very much influences heart disease, very much influences our mood and so forth. So there's a very strong relationship between lifestyle choices, but not only lifestyle, I would say the physical and social environment in which we grow up and function in very much influences our health. And there's new research to show that although in some cases genes predispose you to certain diseases, you can change that course by changing the context and your lifestyle. So it's very interactive. So health isn't just about biological processes, it's how biological processes interact within the context in which we live. Do we have access to nutritional foods? What kinds of environmental toxins are in our community? What kinds of educational pathways can we have? We know that, for example, in the area of dementia, that education, poor education, is a very strong predictor of having cognitive impairment as we age. So our ability, to learn at a very young age how to problem solve and how to deal with a complexity mentally, cognitively, is very, very important. And what happens in our youth actually does determine how we grow old.
Yes, absolutely. How can you work in all these areas that you say to me?
The secret is the team. Okay, the secret is the team. I can't possibly know about genetics and biology without having a team. Yeah. So that's a secret. But the point is that health and lifestyle are actually very complex constructs, and that we need different understandings of them from different disciplines and perspectives. In your specific research programs, you are evaluating and implementing novel psychosocial environmental interventions for adults and their families. What have you found in this process? So, for most of my career in working with teams, I've applied this social ecological perspective in trying to understand how to improve daily life for older adults who may confront, as they age into la tercera edad, different kinds of complexities, feeling depressed or disconnected and socially isolated because their life situation has changed, or because people are often are aging with chronic conditions that may pose some limitations on what they're able to do, or it may impose some kind of limitation on the activities that they wanted to do before. And so if you look from a social ecological perspective and think about what can be changed, what can the person do differently in order to continue to engage in an activity? How can we set up the environment so that a person can continue to engage? And when I say change the environment, I mean not only in their own home or bedroom or bathroom, but also if they're socially isolated, how do we provide adequate transportation system? Okay. Yeah. Another group that we worked with are people who have depression, and another group is people who are living with dementia. Another group are people who are at fall risk. And so applying that lens, we've been able to adjust how people engage in activities and also change their environment to support what they want to do. And we have found that small changes can have huge ramifications, huge impact. So in one of our studies, for example, with cognitively intact but functionally frail older adults, we've shown that we've been able to help older adults re-engage in activities that they prefer and do the things that they want to do, that we can reduce their risk for mortality, and we can reduce hospitalization, we can improve their connectivity to others, and then our work with people who are depressed without using, there's a lot of noise, for people with depression, we've shown that you don't have to use medications, but if you help people engage in the activities that they want and learn how to break down everyday activities in ways that are manageable, that it can improve their mood substantially. So we've had and then for people with dementia, we have found that we can reduce their behavioral symptoms and improve their functionality and improve the way family caregivers interact with a person with dementia and their own well-being. So we found really very small changes to the environment to the way people behave results in very big changes.
How do you see between United States and Chile a similar?
Oh, yes. Okay. From that perspective, I can address that question. So there's similarities, but there's also differences. So first of all, this is a profound difference. In Chile, and correct me if I'm wrong, but health is considered a human right, right?
Consider, yeah.
It's basic premise that everybody has a right to health care.
Yes.
So you have a public health system that would not turn anybody down, right?
Right.
That is not the premise of our health system in the United States. So healthcare is not considered a basic human right. The same thing with long-term care for older adults. That, even if it's not perfect in Chile, it's considered a human right that everybody needs to be cared for their entire life. And in the United States, that's not the premise. Healthcare is an industry, fits a capitalist model, and your health is considered your own responsibility and you have to figure it out.
Pay for it.
So we do not have a public health system. The closest we have to a public health system is that when you're over 65 or over, you can then opt for what's called Medicare. And Medicare pays for basic services.
Wow.
Okay? But you have to be 65 or older. So most Americans have to purchase insurance. If they go to a hospital, to the emergency room, most hospitals will not turn them down, but that's not good primary care, right? People are going to the emergency room for primary care, and it's an emergency, so people are not getting good care. They're not getting dental care, vision care, regular care. So that is a fundamental difference. So yes, can there be improvements in the public health system here? Of course, but you also recognize as a public health system a number of chronic diseases that have now care pathways. I believe diabetes is one of them.
Pathways?
Pathways meaning clinical pathway, meaning that, and I think I'll use the example of diabetes because I think that's one of the recognized chronic conditions. If I go to the public health service because I have diabetes, I follow a particular course of treatment, and that is free. Yes. That's not the case in the United States. That's a profound difference.
Yes.
Yes.
Wow, I am learning.
It's a very sad difference.
Wow.
Yes.
4 questions. One of your interests is connecting research evidence with education programs. Can you explain what is so valuable for you?
I'm going to talk about that with regard to an aging society, an aging world. So one of the biggest changes in our world today is that every country is experiencing a demographic shift where there are more older people than younger people. And so this aging world will require a different way of thinking because the primary condition is a non-communicable disease or chronic condition. And our health systems, in Chile too, is mostly designed for acute care. So our whole system of care has to change. And one of the big issues in the United States, and I think probably in Chile, as I understand it, is that we don't have a workforce that understands aging processes. For example, as one gets older, how one metabolizes medications is very different. So even if you're on the same medication for 30, 40 years, when you're in your 60s or 70s, you may not be metabolizing that medicine in the same way, and adjustments have to be made. So we don't have enough geriatricians who are trained to understand that. We don't have enough occupational therapists, physical therapists, social workers, nurses who are really trained to understand that the primary issue in aging has to do with the impact of disease on daily function. That's what's the most important. Sure, we know how to monitor blood pressure, we know how to monitor heart disease, but what's really important in old age are the functional consequences. So, preparing the workforce for this aging world has become something of great interest to me. So education of the workforce goes hand in hand in terms of generating new evidence and figuring out, we haven't figured out how, once we have new evidence, how do we get it into school so you know how to practice. Like, you have to question, what are you being taught? What's the evidence for what you're being taught? Is it just the way things used to be? Is it historical? Maybe there's new knowledge and there's new techniques. And so we have to get those new techniques and evidence from the research into the educational system of health and human service professionals right away.
Perfect. How has your investigation impacted public policy?
You know, I'm not sure, because in the United States, it's really hard to impact public policy. But I think that my research on family caregiving and the needs of family caregivers, and particularly the needs of people living with dementia, that it, along with many other investigators, have helped to support new policies that we see in the United States, and legislation that has recently been passed that requires all health providers to invite families into a discussion, for example, at the time of discharge from a hospital for older adults. So I hope at some level that the research I've done has contributed to a movement for health policy. I am currently I'm the chair of an advisory council to the Department of Health and Human Services of the federal government in the United States, and we are responsible for advising the Secretary of Health of the Department of Health and Human Services as to what should be recommendations in dementia. So we can only recommend, and I hope to have some influence in that. And the focus of that advisory group has been mostly on, very importantly, recommending more funding for research for a cure. And I've been trying to broaden their lens to include care as well. So it has to be both. It has to be cure and care. So I hope to have some impact. But your question, it made me think quite a bit. There isn't a one-to-one correspondence. Like, you have a study, you have great evidence, and then the world changes. It just doesn't, as much as we would like that, it just doesn't happen like that.
Of course. Think our students watching this video.
Yeah.
So what kind of message can you give them, some advice maybe, for this wonderful profession from your knowledge?
Good. So first, I'm not an occupational therapist, yet I think occupational therapy is a wonderful profession. And I come to Terapia Ocupacional from the world of aging. And when, again, you think about what is the major world trend, it is that our populations are aging. And Chile, as a matter of fact, is experiencing very rapid demographic changes. Very, very rapid. And when you think about what do older adults need, they need occupational therapy. That is the number one profession they need. Because you can take your blood pressure and that's under control. You might have, cancer, and there's cancer pathways. But for even those two diseases that I just mentioned, when it's under control or managed, it's about everyday life. And how do these diseases impact everyday life? Because the older people are going to live older for longer periods of time with these diseases. And it is about their daily function. And if someone doesn't attend to their daily function, actually, the older adult is at risk for mortality, to die sooner. They're at risk for having more chronic diseases. They're at risk for social isolation and depression.
Yes.
They're at risk for other kinds of diseases. So the functional aspects that occupational therapists bring and the lens that an occupational therapist brings is very, very critical. If I had my way, I would assign an occupational therapy assessment and treatment plan for every older adult who has a chronic illness, and that they should be reevaluated by an occupational therapist at any point in time if they experience any changes in their function, in their ability, their participation in activity. I think, honestly, I might get in trouble for saying saying this, but it's almost more important than the 6-month checkups to the doctor. That's what's really important, is that the older adult remain engaged in their community and in their family life and in what they want to accomplish on a daily basis. So OTs are very specially trained, unlike other health professions. They're trained in what? In assessing what the person can do, not what they can't do. Of course, they're trained in that too. But more importantly, what a person can do. And honestly, families and older adults are typically told what they can no longer do. They go to the doctor, they have some limitations, they're told what they can't do. They're not told what they can do. So occupational therapists can understand what the person can't do, but also what they can do, and their cognitive and social well-being and physical well-being, as well as the environment.
Yeah.
And they can put it all together. It's a very unusual combination that is very needed. Now, having said that, occupational therapists play a very critical role in across the lifespan. There's no question. With people, young adults who are traumatized, with spinal cord injuries, with young adults young children who are confronted with, who have exposures to various kinds of traumas. Occupational therapy has a huge role. Yeah. So occupational therapists are really key to across the lifespan. But because my specialty is in aging, I feel very strongly about their role there. And I might say that I had to teach a class last night. I was involved in a class last night in the United States through, an internet connection.
Okay.
And I was asked, why do I work with occupational therapists? Because aren't they really only a profession that works with people in rehabilitation to improve their function? So why do I think occupational therapists should be part of dementia care?
Yeah.
And so I don't know if that's a viewpoint here in Chile, but that's a very narrow understanding of occupational therapy that we have in the United States. About occupational therapist's role is only within a very limited understanding of rehabilitation. Is that...
Thank you, Laura.
Yes, de nada.
Very interesting interview.